Hello, and thank you for joining the Donut of Destiny. This special episode is sponsored by GE HealthCare. References to a specific product, process, or service by speakers during this podcast do not constitute or imply an endorsement by the Society of Cardiovascular Computed Tomography. The views and opinions expressed do not necessarily reflect those of the Society of Cardiovascular Computed Tomography. Thank you for joining us.
Hello, listeners, and welcome back to the Donut of Destiny, a podcast on all things cardiac CT for anyone interested in cardiovascular imaging. My name is Praveen Ranganath, and I'm a radiologist in Dallas, Texas.
And I am Nidhi Madan. I'm a structural interventional cardiologist in Omaha, Nebraska.
Fantastic. Thanks for joining, Nidhi. Today, we have a special industry-sponsored episode of the podcast. Our topic will focus on the role of cardiac CT in planning coronary interventions.
Sounds great, Praveen. Before we dive into our main topic, let's learn a little bit about our special guest we have with us.
Absolutely. That's right, Nidhi. We have an esteemed guest with us today. Joining us is none other than Dr. Carlos Collet. Dr. Collet is an interventional cardiologist currently practicing in Belgium and a well-known leader in the field. His area of research and expertise focuses on the integration of coronary imaging and physiology in understanding complex coronary artery disease. Carlos, welcome onto the podcast.
It's a pleasure to be here. Thank you for having me.
Thank you, Carlos, for joining us. It's an honor to talk with you today. Before we dive into our main discussion, we would love to learn about your practice and what your current role is and how exactly your journey began in the world of cardiac CT.
So I'm an interventional cardiologist. I practice in a small city, beautiful city in Belgium called Aalst, and I am the co-director of the CATLab here. So basically my day-to-day practice is CATLab activities, and I also do some general cardiology as well. So my journey with CT started actually around 15 years ago, and everything started. I was working in another center, and that group, we decided to acquire for the first time a 64 detector scanner to look at the coronaries. At that time, 15 years ago, this was quite, the new thing to look at. They asked who wanted to be trained in cardiac CT, and our colleagues, we look at each other and no one raised their hand. And I said, okay, I want to learn cardiac CT. So it was kind of, but you're an interventional cardiologist. Yeah, I know. But, I think this is going to be an interesting course. So that is actually when everything traveled to the US. I was in the US for 6 months training CT. And after that, things just got bigger and bigger. And actually the moment where CT became one of my main fields of both practice and research was during my PhD. So I did my PhD at the University of Amsterdam, and the PhD was basically to expand the use of CT to complex coronary artery disease. When I started my PhD, CT was something for low-risk patients, and then we decided to take it to the complete other level and start doing CT scans in three-vessel disease, left main disease, and we were really flabbergasted by what we were seeing in those scans. And that was kind of the first time I really said, okay, there's a huge potential here to take this information to better plan and guide PCI procedures.
Amazing. Carlos, there's so much to unpackage there, but let's start first with some big picture concepts. So many of the listeners to the podcast are cardiac imagers themselves, and they know that coronary CT is often touted as the so-called gatekeeper of the CATLab. I'm curious, as a leader in the field of interventional cardiology, how do you feel about that concept of coronary CT as a so-called gatekeeper?
Yeah, so since the NICE guidelines in the UK, then the European guidelines, and lately the US guidelines recommended CT as a first-line test for patients with chest pain, we have seen a complete change in the patients that are referred to the CATLab. And as you said, some people, or there is this gatekeeper term assigned to CT, but actually what is making us in the CATLab is making the CATLab more treatment suite instead of a diagnostic lab. And that for us, from the PCI perspective, it makes a lot of sense because you don't need to have, patient coming to the CATLab without coronary artery disease, getting the risk of a diagnostic procedure without really having coronary artery disease. You really want to have the patients that will benefit from an intervention. So I think that I like the way that CT is actually making this triage. And most of the patients that we have with stable coronary artery disease that go down this pathway actually come to the CATLab for either intervention or a more advanced diagnosis, but we always do something. We seldom see these diagnostic procedures being performed in our lab.
That's such a great point, Carlos. And as you get these patients to the cath lab, the ones that you think have already had a coronary CTA, how do you think coronary CTA data that you have obtained helps you with choosing your procedure, planning your procedure, selecting the catheters you're going to be using, and does it help with saving on contrast load?
Well, there are many phases where CT helps in the CATLab. And I think one of the first things that we have learned is the pre-procedural phase. So actually, before you step in the CATLab, what we have understood is that, for example, looking at this 3D MIP reconstruction of the coronary tree, where you have a lot of emphasis on the calcium, are very useful to assess the complexity of the case. Well, probably you know, but in the cath lab, calcium is the enemy of the interventional cardiologist. The more the calcium you have, the more complex the intervention will be. So we can actually predict the complexity of the case and the amount of time that the case will take just looking very quickly at these reconstructions that are very easy to understand by any interventional cardiologist because we know the coronary tree, we know how to look at calcium. And this occurs everything in the pre-procedural phase. The other thing that we have also learned is that sometimes you have specific cases. You have calcific left main stenosis or you have CTOs. And if you have in your group a team of people doing these cases, these are the patients that you want to have in their program because these are the high volume left main operators, high volume CTO operators, and the case is assigned to the right operator. And we think that is one of the keys of having high procedural success in any program that is doing complex interventions. Now, once the pre-procedural part is kind of look at in the sense you know the complexity of the disease, you have the right operator selected for the case. Now CT can help you in a number of ways, selecting the material in the sense of guiding catheter, for example, but also understanding the need of plaque modification, especially when we talk about calcific lesions, and we're going to talk about that extensively later. But these are kind of elements that we have been learning with experience that tailor material selection to that specific patient.
Perfect. And that kind of segues into what I wanted to ask you about with regards to a granular approach to calcium on these pre-procedure CTs. I'm a non-interventionist, so I try my best to qualitatively and sometimes semi-quantitatively evaluate the calcium in the coronary tree, whether it be per vessel or even per stenosis. But as I had mentioned, I'm a non-interventionist, so I'm very curious to know how you integrate the more granular components of calcium data on CT with what you're planning to do in the lab.
Well, let me start by saying that when I learned CT and we look at very calcific cases, we thought there was a limitation of the method, And then we said, there's a lot of calcium. I have a lot of uncertainty grading this stenosis because of the blooming artifact, etc. And that was kind of this stage of the patient journey where we are focused on the diagnostic question. The diagnostic question is basically, do you have a stenosis? Is there a significant obstruction? Yes or no? And everything revolves around that question. The thing is that the way that we're using the CT in the cath lab, we are trying to address a complete different question. The question of, is there significant disease or not, have been solved. And that patient has been referred to the cath lab. So that's not anymore a question. The question is, what is the best way to treat this particular patient? And now, of course, calcium, that was a limitation, becomes an advantage. So it's one of those things that happen very infrequent in life, where you have something that is a limitation for one part of the journey of the patient, but becomes after an advantage for solving, for example, the need of plaque modification tools. I'm going to expand on this. So the way that we approach calcium is the following. First, of course, we look very in these three-dimensional reconstructions, the amount of calcium, etc., no calcium, a lot of calcium, the location of the calcium relative to the lesion. That's important. The second aspect of the calcium, you have to look at curve MPRs and at the cross-sectional level. And the reason for that is that we have learned from the intravascular imaging field, and when I say that, I'm referring to two techniques called intravascular imaging or IVUS, or optical coherence tomography or OCT. With those techniques, we have identified that there are three elements that contribute to the expansion of the stents. In other words, if you have a lot of calcium with these three characteristics that are thickness, arc, and length, if those three things are a lot or large, then your stent will not be able to expand fully. And what we know is that the major predictor of stent failure is extender expansion. So we have a change of causality here. We have calcium that can be looked very easily non-invasively. That leads to a stent under expansion, and a stent under expansion leads to adverse outcomes. Now, the reason why CT is becoming such an important modality for PCI planning relative to calcium is because with angiography alone, it's very difficult to look at calcium. Sometimes you don't see calcium, and there's a lot of calcium. So we are at the same time kind of using CT to overcome a limitation of conventional 2D angiography. And that makes a lot of sense. So for the listeners that are reporting CT and you have a case that have severe stenosis and are going to the CATLab, what your interventional cardiologists need to know is, one, what is the arc of calcium? Is that 180 degrees? Is that 380 degrees? That's very important. Second, is that a thin calcium or thick calcium? You have to play with the window with, and then you will see how thick is that calcium. And finally, the extension of the calcium in the longitudinal plane. How long is that calcium in the vessel? And these three things are very important for us to determine whether it's going to be a simple procedure. Simple procedure, I'm referring to balloon, you took a balloon, you dilate the vessel, then you put a stent and you're finished. Or you need to engage into more complicated techniques that are specifically meant to ablate the calcium or to fracture the calcium, which are things that we know how to do it, but we need to be aware of the calcific burden in that particular lesion.
Thank you, Carlos. I think calcium, like you said, is a big problem when we come down to dealing with our interventions in the coronary field. The one thing other than calcium that we also look at as an interventionalist is the length of the lesion. We talk a lot about that. We talk about the tortuosity in our vessels. And these anatomical findings can also come from our coronary CTA that we have obtained. These can also come from the coronary angiography that the patient is there to have. How do you think the coronary CT sort of adds to or potentiates or helps you if you've obtained it prior to the patient getting to the cath lab?
Well, that's a very good question. And the explanation or the answer has two different levels. The first one is that CT allows you to select the angulation where you're going to see the lesion completely in the whole length of the lesion. And sometimes when you're working again with 2D angiography, you make a projection and you have some sort of foreshortening. So you don't see clearly the complete extension of the lesion. And then visually, because most of the procedures, we actually select the material visually, believe it or not, sometimes we call it short. So the stent is probably too short for the lesion, and then we end up putting another stent, or sometimes we miss part of the lesion, which is one of the factors leading to adverse events after PCI. So knowing the angulation from the CT scanner and be prepared to perhaps put the C-arm in a position that is not the normal position, let's say, that's an important element to really understand the lesion length. Now, the second aspect relates to the fact that CT is a three-dimensional modality. So everything that you are measuring comes from the three-dimensional space. That has an inherent advantage to any other modality in the CATLab. And I'm, of course, talking about angiography, but I'm also talking about IVUS and OCT, because these are derived from intravascular imaging catheters that distort the shape of the vessel. You get a measurement, but that measurement doesn't follow actually the path of the vessel. You have modified the path of the vessel with the material. So I like to say that CT is the gold standard to assess length in the coronary tree, because you're working again with the natural morphology of the vessel and you're measuring the length in a very specific way. And this is the way we're using actually CT to select stent length.
I want to combine these ideas that we've talked about in calcium as well as lesion length with regards to the differences between planning with the CT beforehand versus what one would do in the cath lab with intracoronary imaging. We mentioned IVUS and OCT. So could you talk us through some of the differences and similarities between your approach to intravascular coronary imaging versus coronary CT?
Well, I think that CT and both modalities of intravascular imaging complement each other. And there are a number of reasons for that. One of the things that we have seen with CT is that it provides an information that is very difficult to obtain with intravascular imaging. And I'm referring to the fact that you can have the plaque and the calcium in the three vessels in bifurcation lesions. And to get this information from intravascular imaging is very complicated, because you have to put the imaging catheter to one branch and then change all the material, go to the other branch, and then try to combine that information. And again, with CT, it is so easy to understand, for example, the distribution of calcium at the level of the bifurcation. And that, in my view, is an advantage compared to intravascular imaging. Now, of course, we need to recognize that intravascular imaging has both OCT and IVUS have a higher spatial resolution compared to CT. So what I think that CT offers is the big view. What is happening? Where is the calcium? What should be aware of? If you really want to go with a higher level of detail, you need to use either IVUS or OCT to understand better the characteristics of the calcium from the inner side of the coronary vessel. Now, one of my current fields of research is actually calcium, in the sense that we believe that using all this information coming from IVUS and OCT to train models that are segmenting and looking at calcium from the non-invasive imaging from CT, I think the potential is huge to have a more accurate segmentation of calcium and more accurate understanding of calcium from the CT with, again, images trained with IVUS or OCT. I'm going to make a last comment, because the most used imaging modality in the CATLab is IVUS. It's more used than OCT. But IVUS has a big limitation when we look at calcium. IVUS is a sound-based technology, and the waves are blocked by the calcium. So every time that you have calcium, you have a shadow behind the calcium. So you can understand the arc of calcium. That is easy to look with IVUS, but you don't know about the thickness of the calcium, because everything is black after you have seen the white structure. CT complements IVUS by telling you what is the length, that is the thickness, behind that calcium. And that is crucial, because then you are looking at two modalities to look at the same structure that complement each other. So this is the way that we're trying to learn from the invasive imaging to understand more what we're looking with CT, and vice versa.
A pause for a word from our sponsors.
GE HealthCare is glad to be the sponsor for this episode of the Donut of Destiny podcast. GE HealthCare is the leading global medical technology, pharmaceutical diagnostics, and digital solutions innovator dedicated to providing integrated solutions to make hospitals more efficient, clinicians more effective, therapies more precise, and patients healthier. Learn more on our CT solutions on the GE HealthCare website.
And now, back to the show.
A few things you mentioned in the complexity of our coronary interventions. We talked about calcium and the anatomical features that guide our intervention. How do you think CT plays a role in some particular cases of bifurcation lesions or left main PCI, CTO PCIs? I think these are all topics which are very challenging for our interventional cardiologists. And if CT allows us to learn more prior to embarking on these interventions, I think a lot of our listeners would love to hear that.
Yes, so I think that that's a great point, and again, I think that you have mentioned them all, but there are three very challenging scenarios for us. One is, of course, calcific lesions that we have talked about. The second one are bifurcations, and the third ones are CTOs. And I think when we talk about bifurcations, there are a couple of things that comes from CT that are very important. The first one is the fact that we can estimate the myocardial mass at risks of the side branches involved in the bifurcation. And this changes completely the PCI strategy. If you are dealing with a side branch, so bifurcation has a main branch and a side branch, and if you're dealing with a side branch that actually subtend a small myocardial mass, you will be less aggressive in your PCI techniques in contrast to cases that you are dealing with a side branch that has a huge 10, 15, 20% of the myocardial mass. And that has been for us an eye opener. We're calculating mass at risk of all the side branches. And I have been sometimes surprised by the fact that side branches that I thought angiographically would be big are actually very small in terms of the mass that they supply blood. And vice versa. Sometimes you say, oh, that's a small branch. No, it's 12, 14% of the myocardium. Oh, I don't want to lose this branch. That's a branch that you don't want to lose. So these are, it's a small detail, but it really makes a difference when you're dealing with bifurcation lesions. So I think that makes a lot of sense to look at bifurcations to add to all our bifurcation thinking the mass of the side branch, and that changes your technique most of the time.
Amazing. And beyond just bifurcation lesions, can you speak to chronic total occlusions or other very complex long segment stenoses and how CT adds, if any, incremental value beyond just angiography in planning for those cases?
Well, CTO is a special field, and perhaps you're all aware, but the field of CTO, interventional cardiology, has developed almost as a new specialty. Now we have CTO operators that are not the normal operators, and I consider myself a non-CTO operator. What I think it's CT in the field of CTO has a big role. We have randomized clinical trial data in this field showing that CT guidance for CTO procedures increases the success rate of the procedure and reduce complications. So these are two important elements, again, with evidence already published. So that's an important point. The way that I use CT for CTOs is to understand the complexity of the CTO. Sometimes you have CTOs that are very simple to treat. These are short CTOs without calcium. These CTOs are the CTOs that, in my view, I put it in my program, I do it myself. And then you have CTOs that are very long, calcific disease, that you said this is going to be a very tough procedure. This has to be done by a specific, a dedicated CTO operator. And these are the ones that I defer to my colleagues because they are the ones doing this on daily basis. So I think that CT has a very important role in CTOs. And again, the role is to stratify the complexity of the CTO, and that would basically define who will perform the procedure.
That sounds great, Carlos. As we are on the topic of planning our procedure, I think I want to ask a little bit about technology relating to CT called CTFFR that many of our listeners must be familiar with and may even be using it in their practice. As we approach these complex lesions, could you speak to us about how that helps you when you're looking at multiple stenosis, multi-vessel disease, serial stenosis in one vessel, and plan your stents?
Yeah, so I've been very deeply involved in all the invasive physiology field as well, and we are seeing a revolution in coronary physiology at this moment. And the revolution comes because we are not using the technology, I'm talking about FFR, in the same way that all the trials and the technology was developed 10, 20 years ago. 10, 20 years ago, what was important or the question that FFR came to help us with was, is this lesion significant? Is the flow diminished or reduced by this epicardial lesion, yes or no? And then FFR gave you the answer. That's very good. Now, that's the way that it was used before. The way that we're using physiology today is what we call second generation physiology. And what is this? This is beyond looking at this threshold of significant, not significant, less than 0.8, more than 0.8 FFR. We're looking at the way that the pressure is lost along the vessel. And two things can happen. One, that you have a stenosis that has a focal pressure gradient. In other words, all the pressure is lost within that lesion. Or you have the opposite case where you see a gradual decrease in pressure from the proximal part of the vessel, and it goes slowly down to the distal part of the coronary. Now, at the end of the vessel, the FFR can be the same, but the response to therapy is completely different. If you put a stent, if you treat a patient that has focal disease based on FFR, if you place a stent in those cases, the blood flow improves significantly. And those patients, we have demonstrated recently that they are completely free from angina after the procedure. Now, not surprisingly, if you have these vessels that sometimes you will see stenosis and you'll say 50, 70%, I see it here, but it's diffusely diseased from the functional point of view, you might put a stent in the obstruction that you can see anatomically. But that obstruction is not producing a large translational pressure gradient. So that stent will not improve blood flow. And again, what we show in the same work is that these patients remain with symptoms after having a successful procedure based on angiography. So these are things that we are learning. So the way that we're using FFR CT today is, yes, it's significant. That's the first question. And again, that's a diagnostic question. But the planning question is this a case that is focal for PCI? Or is this a case that is diffuse, perhaps to manage medically or maybe surgery? But we already know that PCI is not the best answer. So again, this is research in progress. So we're working on this as we speak. But I think this is the way that FFRCT will be used in the future to answer first, is this significant? And second, this is focal and diffuse. And that will kind of tell us what is the best path to treat that patient.
I want to expand a little more on this idea of FFRCT or wireless physiology, if you will, in cases that have been brought to me from our interventionists, where there's some confusion about the CT appearance, FFRCT, and subsequent angiography. Two examples that come to mind are cases of serial, apparently moderate, severe-looking stenoses anatomically, and how to interpret the FFRCT data in the setting of severe serial stenoses in a lesion. And second, in cases with very tortuous vessels, oftentimes patients that have had chronic uncontrolled hypertension, and seeing a gradual drop in FFR-CT values across the vessel. Is there anything from the invasive physiology space that we can apply to our interpretation of FFR-CT in those more complicated cases?
Yes, of course. So FFRCT mimics invasive FFR, and all the validation of FFRCT and all the models that are continue learning from the invasive data comes from FFR. And the field of serial lesions is fascinating, because what we need to understand that sometimes is not straightforward is that the amount of pressure reduction from an obstruction depends on the amount of flow that goes through the obstruction. In other words, it is completely different to have a 50% stenosis in the proximal LAD than a 50% stenosis in a marginal branch in terms of FFR. Why? Because the amount of flow that goes through the proximal LAD is 3 times higher than the amount of flow that goes through the marginal. So, with the same anatomical stenosis, you're going to have a very reduced FFR in the LAD and a normal FFR in the marginal. And it doesn't mean that the lesion anatomically is the same, but it's because the amount of flow is what determines the pressure loss. That is an important physiological concept to consider. Now, why am I telling this story? Because you ask about serial lesions. And what happens in serial lesions is that, imagine that you have 2 lesions. The first lesion will reduce the flow that goes through the second lesion. And we already learned that if the flow is less, the amount of translational pressure gradient or the translational pressure losses in the second lesion will be less. So imagine that you have 2 lesions in the LAD, and the proximal lesion will reduce the flow that goes through the second lesion. And because you have less flow coming to the second lesion, the amount of pressure loss will be lower than in the case that you wouldn't have the first lesion, where the flow will be higher. So lesions interact with each other in this way. So if you remove one lesion, you will see increasing flow, and then you add more gradient. And that is normal. That is just the basic principles of fluid dynamics. Now, there is one point to mention here that is very, very important. Since perhaps 10, 15 years, we have been trying to develop ways and algorithms from invasive physiology to predict what is going to happen if I have serial lesions and I remove these lesions. And there is a ton of papers looking at complex mathematical regressions that no one uses in clinical practice, but they're published, and they doesn't work. Now, what is actually being developed from the FFRCT side is a tool that we are now validating in a clinical trial called the FFRCT Planner. The FFRCT Planner, in my view, is one of the best approaches that we have to assess serial lesions. And I will explain you why. When you have this model with the FFRCT and you place these virtual stents, the flow is recalculated automatically after you remove one lesion. So all the numbers in the artery change after you put a virtual stent. This has been validated by a team of investigators from England, and they have compared that with the classical approaches based on the invasive pullback curve. And they show that this approach, that is the virtual with the automatic recalculation of the flow rate, is superior in terms of accuracy to the invasive part to predict what would happen if I put a stent here, I put a stent there. So CT has a fascinating potential to understand these complex diseases, in particular serial lesions. And I'm going to also go to your second question, which is also very nice, which is the vessels with tortuosity. These vessels are a nightmare in the CATLab. No one wants to put a pressure wire down those vessels because you straighten them up. You don't know where you're measuring anymore because all the pressures now have an artifact because the vessel has no flow anymore. So that is a problem. Now, one of the things that we have learned from all these simulations, that we call that computational fluid dynamics, is that when you have all these bends, you are losing pressure in every bend of the coronary. And then you may have, I have seen this, it's infrequent, but you see it specifically in the cases that you mentioned, hypertensive patients with the tortuous vessels. When you calculate the virtual pressure losses, you get suddenly a decrease in pressure along the vessel. And people say, but there is no lesion. Yes, but there is a lot of friction. There are a lot of eddies of blood in all this curve. And those fluid dynamic elements of the blood flow in the coronary makes you lose pressure. You lose pressure along the vessel. And that's the reason why these vessels are sometimes considered positive from the functional point of view. And perhaps it's true, but this is the mechanism behind.
Those are great points. And those are definitely some technically challenging scenarios you've described, Carlos, for us. I am more curious now to learn your perspective on maybe some post-PCI issues that we talk about. Do we always check for FFR post-PCI invasively? Or is there a role from CT standpoint regarding that? And some newer technology that might be coming our way that you can maybe shed some light on.
Nidhi, I think you have touched upon a very important point. And we are very excited about the potential of CT for pre-procedural planning, for guiding procedures. But this is all related to the pre-stent part of PCI. Once you have modified the vessel, once you have intervened, balloon, or placed the stent, the CT is of little help after you have modified the vessel, simply because it's an static image acquired before the procedure. Now, in this particular phase of the procedure, the most important, of course, is to assess whether the stent was well expanded. And the best way to do that, or the classical way to do that, is again by using now intravascular imaging, either IVUS or OCT, after the PCI to check that the stent has been well place. Let's put it in those terms. Now, what we are seeing from the angiographic part is a new revolution in angiography itself. And there is a new tool called 3D stent that is based on rotational angiography that reconstructs the metallic stent in 3D and enables you to actually measure the areas of the stent that we know are associated with adverse events without the use of intravascular imaging. This is completely new. This has been in the market since a few months, I believe. And we believe that it will just help us understand better, one, how the stent was implanted, if some more interventions are needed to expand the stent more. And I think this will just result in better clinical outcomes. So we are seeing that, again, that advance from the angio part as well.
That sounds really exciting to me. If we can learn about our outcomes or learn about our stent implantation techniques post-procedurally or intra-procedurally and do even better than what we are doing. Sounds like we have a lot of new exciting things on the horizon. I learned a lot from you, Carlos, today, and I'm sure our listeners feel the same way and have probably picked up some of the things they can utilize in their practice. I want to ask you maybe one of the final questions. What are you most excited about that you see in the future?
I think that CT became the first line test. So most of the patients are already getting a CT from the diagnostic point of view. And learning how this technology is helping us in the CATLab is just, we feel that we're really taking a step forward in the field of intervention. Now, the frontier that we are now getting to is having the CT inside the CATLab. So the way that we're doing this is we are putting the CT images reconstructed in colors to make it very simple to understand next to the conventional angiography. We're synchronizing this with the C-arm. So every time that we move the C-arm, we know exactly what we're going to see before we put our foot on the pedal. So we're going to save radiation, we're going to save contrast. And the CT image complements the angio in the sense that it allows you to know where the plaques start, where the plaque ends, the type of plaques that you are treating, that were elements that have not been considered within a normal procedure in the last 10, 20 years. So I do believe that the integration of CT in the CATLab is very powerful. I think it will certainly help to do better procedures. And we're doing a randomized clinical trial now to prove that this approach actually improves clinical outcomes. So a lot of things happening, a lot of evidence being generated, and a lot of learning points as we go in this journey, because this is something that is just started. And we feel very grateful and lucky to be leading this approach. But I think many things to come in the future, and certainly in the CATLab. I used to say that in the CATLab of the future, the CT will be integrated, but this is already happening in my CATLab. So I think that in the future, all CATLabs will have a CT integrated because it makes so much sense and it helps us so much overcoming some of the limitations of conventional angiography.
Carlos, that was fantastic. I feel like the three of us could talk about this sort of forever, but I think now is an appropriate time for us to bring the conversation to a close. And as we bring it to a close, we really want to extend our thanks once again for bringing your time and expertise for our listeners and really the whole community altogether. So truly, thank you from us in the podcast, from us as a SECT, and from the whole scientific community for everything that you've done.
Thank you, Carlos. This was just a fascinating conversation, and I just can't wait to be part of the future and see what is there for us.
Thank you very much for having me again.
Of course. Thanks again, Carlos. And for our listeners out there, thank you very much for tuning in. Remember, if you like what you hear from us on the podcast, please rate, review, and subscribe to us. Once again, this is the Donut of Destiny. Cheers.